Now, since the start of the COVID-19 pandemic, medical interventions are being tried to help patients with severe symptoms. The Ministerial Advisory Committee on COVID-19 has not endorsed the use of a certain procedure that involves bronchoscopy. Well, you want to know what bronchoscopy is? We're going to find out from our next guest. However, it says that these procedures they can be used as an intervention for severe patients under strict protocols. Now, Dr. Emmanuel Tabang has used this procedure. He joins us now in studio to talk about what he's discovered and why it is that this procedure does not have the blessing of the World Health Organization, needless to say, our very own health department here. Doc, thank you very much for making time to talk to us. It's absolutely wonderful to talk to you in person, having seen the story that was run. I've got to say, because this I saw on their channel. It was Carte Blanche that ran your story, and I think it is absolutely remarkable what we saw in that piece. Just explain to us very plainly what it is that this procedure is, and what do you do for the patients who are suffering with COVID-19?
Thank you very much, and thank you for the listeners out there. You know, the issue about bronchoscopy is just really a fiber optic kind of tube or channel that contain lights and a pipe for suctioning, and also a small area where you could actually do biopsy. So it's not really a new procedure. It's been around quite for a number of years, 20 to 50 years, was invented previously in Japan. And I remember that the gentleman who invented bronchoscopy, he was diagnosed with TB, but the TB was diagnosed late. And he thought about an idea of what if you could put a camera in the lung and wash the lungs and get some kind of results earlier rather than waiting for sputum, because some people didn't have sputum at that particular time. And that's when bronchoscopy was invented. And of course, after bronchoscopy, a lot of other things were invented like gastroscopies and all those. Those belong to one by since that invention. So as a pulmonologist, I specialize in lungs. Lungs being my area of specialty, and if I could say that it's actually my passion.
Yes.
Yeah. So when COVID-19 came, was surfaced in 2019 toward the end of December. The issue that there were a lot of rumors that actually not rumors, it's been facts that the infection was contagious and spread from person to person through aerosols.
Yes.
And that time, of course, everybody went into panic and fear that if you perform bronchoscopy, you increase the aerosolization of the COVID-19, and most likely most of your staff will get infected. And I think in March, even there are some Spanish doctors who attempt to do bronchoscopy, and 1 out of 3 of them were infected. So that was the fear. And yeah, so then of course, when COVID arrived to us in June this year, we started having a lot of patients actually with COVID that were in the quiet life support. And yeah.
So doctor, you've just explained to us that some Spanish doctors tried this at the very start of the first wave that hit the world, and they weren't necessarily successful. If anything, they got infected. But you've decided to try it, and it's worked. For how many patients has it worked?
Well, I've done quite a lot of patients now. I think if I remember, with the first case that I did was in June. Because what the Spanish did was to diagnose COVID-19, wasn't really looking for mucus. They were looking for diagnosis of COVID-19, and that was then World Health discouraged that you cannot do bronchoscopy because you're going to increase number of people. And we, of course, then there was literature coming out that actually COVID-19 does not cause mucus plug. So there was no need actually for you to do any kind of procedure, because when you listen to these people's lungs, you hardly feel anything. You don't hear any noise coming from the lungs, like as compared to patients with pneumonia. So hence, bronchoscopy was kind of discarded. That was not actually useful in patients with COVID-19 until, of course, in June, when I started seeing patients. You saw it from Italy. There were a lot of videos going around that patients with COVID-19 for the first 7 days, they will do very well, and they will be taken out of life support. And then after 7 days, those patients develop what we call H-type. Okay, means the lung become fibrotic, difficult to ventilate, they require more oxygen, and those people actually die. And my concern was that, well, when you read the literature first, it sounds very credible. But when you think back as a pulmonologist, you cannot develop lung fibrosis within 7 days, because those patients actually, they do very well at the beginning. You find that their oxygen level improve, and after 7 days, you find that they're becoming worse and worse and worse. I remember my 3 patients that I had, one was having saturation of 90, every day dropped to 50, 80, until dropped to 20, then they die. I remember 2, 3 of them, and they were previously doing very well. So my concern was, what then? What's really happening?
Yeah.
You know, and were they right that actually is it lung fibrosis? And if lung fibrosis, why should it happen within 7 days? You know, I mean, lung fibrosis means irreversible and should be taking longer actually to develop.
Right.
And that's when on my 4th patient, who was happened to be a colleague, and I decided, you know what, the best is let's look into these people's lung and then see what happened. Because what's the point of doing post-mortem? I mean, post-mortem were done. Unfortunately, on post-mortem, you find someone who is dead. You cannot bring them back. But what if you do ante-mortem? Do the bronchoscopy early and see what actually happened in these people's lungs, and maybe take a biopsy while they're still alive. And that was what entrenched me actually to do bronchoscopy on those patients.
And since you've started this procedure, doctor, again I ask, we are now sitting in the second wave of COVID-19. How many patients have been saved by the very procedure you've
I could
performed?
say that probably I'll be looking at about almost 40 or 50 patients within my unit, yes.
All successful?
Successful, yes.
Wow. I guess people listening to you right now, they're asking themselves why it is that this procedure is not just being discouraged by our own department here, but it is discouraged by the World Health Organization. That's the world body. Could it be that looking at how you're performing it, you think that they might relook their decision?
I think they need to relook their decisions, because it's really very important, because patients with COVID-19, actually, what happened that, yes, there's no treatment, but I think that they need to buy times. Okay, so means when if you decide to put someone on life support, you're saying that this person got good prognosis. So means as intensivist in ICU, you ought to do everything for these people. Means you have to go all out of the way and kind of save their lives. And we know that patients with COVID-19 in ICU, they die, in midstream, they die because of 4 things. One of them is the mucus plug, which is probably one of the major issues. And second thing is infection. And thirdly, about ventilator, if you don't know how to manage your ventilator properly. And then 4th thing, probably cardiac problems. And if you eliminate all of the above, you manage this problem properly, mortality almost dropped to almost negligible. And that's the reality.
Dr. Taban, we are going to continue this conversation in just a moment, and I'm going to ask you about the possibilities of you being sued if anything goes wrong. We live in a litigious society. The issue of medical malpractice is there, but we're going to continue that conversation in just a moment, and we'll be back in one moment. Very good afternoon to you. If you're just joining us, we are in conversation with Dr. Emmanuel Thabane, and he's pioneered this new procedure to try and help COVID patients. And while many of us, Dr. Thabane, would think that you are doing a good thing here, let us not fool ourselves, because, as I said earlier, we live in a litigious society. One mistake happens and there you are. You lose your medical license. Are you not afraid that with this procedure that you are performing, it is not encouraged, let me put it that way, by the health department, nor is it encouraged by the World Health Organization? Should something go wrong, are you not afraid that you may lose your license?
I think as a doctor, when we qualify, we kind of take a Hippocratic oath. That's saying that we will do everything not to harm our patient. And that's what I stand by. So I'm not worried about medical negligence, because it's definitely not a negligence. The issue that bronchoscopy work well in patients that are hypoxemic, patients that are going to die. And saving their life, for me, is more important than losing my own license. If that means that I have to lose my license and start selling tomatoes on the street, I'm happy for that. But for me, every life matters. I mean, you know, around the world, people are going on the street about Black Lives Matter. I mean, so clearly that people who covered are people that got good prognosis. So we ought to do everything. And
Doctor, have you made a presentation to the health authorities in South Africa to say, this is what I'm doing? So far, I have saved the lives of just over 40 patients, as you mentioned. Why should we not look at this procedure? And I'm going to talk about the second wave in just a moment, which is seeing a lot of deaths as a result of this COVID-19. But just that first question, have you made a presentation to health authorities, and what have they said to you?
Yes, I did presentation, and what actually, because they were asking me how easy to set up the bronchoscopies. And I think based on my presentation, I did explain quite a lot of things. One of them is that I think patients with COVID-19, you first need to get a basic principle of managing this patient properly before even you consider bronchoscopy. Because bronchoscopy, you need to have a skills. You need to be an expert. And it's done by a few specialists in South Africa, pulmonologists, cardiothoracic surgeon, and bit of intensivists, some of the intensivists. So it's not done by everybody like physician or GP, no. It has to be done by people that are trained to manage patients in ICU. And you have to have kind of a guideline how to do them. The issue that like in midstream, we did them under what we call negative pressure room, and means it's very safe. And lately, there's actual literature that come out in the chest physician America, actually that proved that bronchoscopy is very safe. And looking at what I've done in midstream, it's extremely safe because I haven't lost any patient due to bronchoscopy. All of them survive. So the question is that, why are you afraid of it?
And what has the response been of the health department after you made that presentation?
Well, they say they support they support as contrary to the news, the report that they released. The report that they released actually is not a very bad report. They do actually allow us to do bronchoscopy. But what was actually shortcoming of that report was that they haven't looked at the preventive measure. You know, the issue about my discovery of mucus plug was something very special to say that patients with COVID-19, number one, they could develop mucus plug. That's number one. Number two, what do you do about the mucus plug? You know, so we have to do something before the patient actually develops mucus plug. So it means public need to be aware about presence of mucus plug in patients with COVID-19. So it means you can use preventive measures such as using mucolytics, like medication to thin your mucus while you're still strong enough. And now those who end up in ICU, then of course bronchoscopy will come there, the treatment of choice. But again, that should not be done on everybody. Must be done on people after the 7, 8 of their life support, of people that has that worsening. And if you look inside, you'll find something. I've done it. I mean, recently I did one at day 3, and the tube was blocked. And we removed the tube, did bronchoscopy yesterday. I extubated him after 5 days on life support.
Yeah.
So, and what I've seen, the current patient, they actually increased amount of chest symptoms as compared to the previous.
Doctor, we into the second wave of this coronavirus pandemic. How many patients are you seeing? I'm even afraid to say per day. And I imagine that when someone is in hospital, the situation is serious enough. How many patients are you seeing? Before I ask about your opinion on the death rate that we are seeing.
I think we have seen the highest patient in our hospital. We have almost about 80 COVID-19 patients. We have about 30 in ICU and 15 in high care. And we are a very small hospital, about 169 beds. And we have almost about 27 on ventilators. And last night, we didn't have enough ventilators when 2 of the patients crashed. We have to use an anesthetic machine to ventilate them, because currently they don't have ventilators in Gauteng, all over Gauteng. There's shortage. And that
of
means
ventilators in Gauteng.
Yes, exactly.
Right now,
and I mean, we're talking about private hospital, not government either. It's private hospital that you don't even have a life support to help someone. So if you collapse today in midstream, there'll be no ventilator for you. And that's the reality.
The demographics of, or the demographic profile, doctor, of the patients that you are seeing. In the first wave, we were told that the people who are at most risk are elderly patients and definitely people with comorbidities. This time around,
we're seeing more younger patients between age of 30 to almost 60 years old. And most of them actually have no comorbidities, but they're having a severe disease. And I've seen quite younger patients between the age of 30 and 45 with a lot of cardiovascular problems. And that's really very, very scary.
These are young people with cardiovascular problems.
Yes.
Once they've contracted this COVID-19, they present with this...
cardiovascular issues.
Basically, this is a heart problem, cardiovascular.
Yes.
What do you think is the reason for that? Is it a lifestyle issue? What is it exactly?
I think that it's difficult to know what is the variant, but I mean, previous was discussed, but not to the extent that we're seeing in current population of patients. And I think also because more to do with most of them got an increased BMI, body mass index, almost between 31 to 35.
Weight
issue. So weight was a bigger issue. And then, of course, most of them could have been pre-diabetic, though they were not diagnosed as a diabetic. And most of them also might have underlying hypertension. Yeah, so that's the major issue.
And I hate to ask this question, but how many of these young people are dying? Because we were told that the people who succumb most to this virus are your elderly patients and those with comorbidities. The younger people that you are seeing, are they surviving it though?
I think midstream, up to now, we have lost about 4 patients since the second wave. 2 were elderly, which were not supposed to be put on life support because they're age of 83 and 86. And then 2 were young, one was 60 and one was about 39-year-old who came and died because of cardiovascular dysrhythmias and died immediately within 24 hours. Otherwise, most of our patients, they actually did very well. Some went home. So we have so far so good. But I mean, if you look at the mortality around the country, it's very alarming. I mean, the number of deaths is quite compared to the first wave. I mean, if you carry on in the same degree as now, probably we're going to be reaching about almost 50,000 deaths before the end of January. And that's really, really very worrying.
And I've got to ask you the question, what do you think is driving this death rate that we are seeing now? You're saying compared to the first wave, the level of people dying or the rate at which people are dying is much more alarming than what we saw in the first wave. What is the cause, doctor? Because also what is strange here is that we are in the middle of summer. At some point there was this talk that the virus is much more
virulent during winter.
Exactly.
Yeah.
So what's the reason people are dying like this in summer?
Yeah, so the question is whether, because I think probably they say, I think most people who come and die, they die because hypoxia. So means they don't come to get the assistance from the hospital immediately.
Early enough.
Yeah, so because one of the first treatment of COVID-19 is oxygen. You need oxygen. And if you come late and then there's no infrastructure, no ICU beds, or no oxygen ports, most of these people will die, late presentation. And second thing, probably we lose a lot of patient in ICU, which I think for me, I would say that if you look at my mortality, compared to within the Mediclinic group, we have the lowest mortality in midstream as compared to others, though we're having highest number of ventilated patients. So whether it's more to do with the management of these patients and whether to do with the mucus plug, which play major roles, whether it's infection, but I think it's difficult to know. With bronchoscopy, there are very few people in South Africa that does bronchoscopy on those COVID-19 patients.
Yeah.
So on my understanding, I mean, if you compare the second wave in UK and compare the second wave in South Africa, it seems like we haven't learned in South Africa. It looks like it's like our first wave because we're losing more patients as compared to UK where they're losing extra less. Their death drop almost to 12 to 11%.
Yeah, and that's what I want to come to next, to say if the rate at which people are dying overseas has come down significantly, even though the infection rate is clearly getting out of hand, there's something that they are doing there to try and get their patients to survive this thing. Is this bronchoscopy procedure that you are performing being practiced in any of the countries in the Western world?
I think we have a meeting that was in November last year in Germany, I think, or with World Health Organization that I attended once. And I asked one of the doctors from Germany, who, because they're quite more first world country, they have like statistical patients, they have that time about 3,500 people on ventilators. So I asked whether actually if they do bronchoscopies, and the answer was yes, they do bronchoscopies if indicated. Okay, so it means most countries around the world, they do actually do bronchoscopies. But the issue I think in South Africa is that I think for me, patients with COVID-19 should not die if we eliminate mucus plug, infections, and manage them ventilator-wise. They just need time. After time, they recover. I've seen patients with the worst disease, after 4 months, they still go home. They resume their life normally.
In this second wave, Doctor, that the world over is experiencing, are you aware of specific countries that are doing exactly what you are doing, which is what we are interviewing you about here, this new procedure?
I think Germany does it, Spain does it, and then also I'm not so sure in US, but I know that most of these two countries, and I know Sudan also does it, United Arab Emirates does it, and also South Africa, a lot of doctors also do them, bronchoscopies. But the question whether they do them based on that timing, based on the literature that we presented within 7 days. Of course, if you do it after 2 days, you will not find mucus plug and you cause more harm. So it must be done when the patient is hypoxemic, and means you have to look at the guideline that we have published.
Final question to you, Doc. Right now in South Africa, everybody is angry at government, I think, for lack of a better word. They're angry at government because government is accused of moving slowly in procuring the vaccine, the COVID-19 vaccine. Is that the ultimate solution, in your view, the procurement of this vaccine?
It's difficult to say, but the vaccine is absolutely very important. I think it's a part of game changer for most people, especially that if it works. I mean, we know that the vaccine is really a year old. I mean, we've been waiting for a lot of vaccines, including HIV, malaria, and we haven't gone for a number of years. But this was developed within a short period of time. So, but of course, if it is present, it would be one of the game changer, probably reduce the number of the COVID patients. But I think COVID will be with us quite for a long time in our lives. That's the reality. But even though after COVID, you still need to manage these people in ICU. So I think we need to look at it comprehensively. While we're waiting for vaccine, I mean, based on what I hear from news, that the shipment of 1 million vaccine coming from India in a number of weeks. I mean, politicians say number of weeks. Weeks could be 100 weeks, 1 million weeks, nobody knows. But while we're waiting for the vaccine, I think we should be doing more for our patients currently. Those who are in life support, we should be able to improve them and try to get them out, save their lives. Not saying we're waiting for them for the Messiah, who is the vaccine. I think we should be doing something now.
Well, Dr. Emmanuel Thabane, thank you very much for talking to us, and the work that you do is indeed inspiring, and I can't tell you just how in awe of you I am. The level of courage that you have to say, if I lose my license, that's fine. I'll go and sell tomato in the street. But when I signed up to be a doctor, I said, I will get into this to save patients' lives. And I guess that's the motto that you say is driving you. Thank you very much, and best of luck to you going forward.